There's a fair amount of research out there at this point which has looked at survival in hospice care as opposed to survival in so-called usual care. And in none of those studies so far has survival in hospice care been shown to be shorter. One of the things when I'm talking to patients about the idea of end-of-life care, hospice care, palliative care, is that none of us has stock in the patient being dead. That's not our goal. Our goal is the patient being comfortable. The position that we take in our agency is that if we are doing comfort well, then euthanasia is unnecessary.
I guess I'd add to this discussion about intention matters very much in terms of what we're doing. And so in the hospital, when someone's at end of life, like the gentleman I told you about whose lung disease was so severe that he had to be sedated just so he didn't feel the suffocation. One of the questions from the physician who called me was, "I'm afraid I might be killing him," which is another way to talk about euthanasia. And so much of the conversation to help him get from A to B was, what is euthanasia? Do you intend to kill this man by carrying out his living will? No, my intention is to carry out his wishes, but I'm concerned because he's on all that medication. Tell me why you have him on all that medication. Well, because his shortness of breath is so severe. And really all we were doing was talking about what was in his mind as the physician guiding the care. The intention was clearly about comfort and about carrying out the patient's wishes and about recognizing that he was at life's end. And so that all made it work for him. Legally and ethically, we talk about this as when a patient decides to come off life support or a physician decides to honor a living will, we actually specifically say in our statutes that is not euthanasia.